note, some of the program requirements discussed today may differ across jurisdictions. For those of you not aware, we're in Ontario, so be aware of that. So further review might be required, when developing your organization's policies, procedures, and things like that. Before we begin, just a couple of housekeeping items. As you can see on the screen, if there's any issues with the audio, just double check your settings, your audio settings, and adjust accordingly. I alluded to questions, so we will entertain questions at the end of the presentation. Jason will, so you can enter them into the chat. And if we, for some reason, don't get to all of the questions, we intend on posting Q&A to our website afterward. Okay, so we'll do our best to get all of that information out. Following the webinar, as soon as we can get to it, we will be posting. We are recording today, the main part of the presentation, so we will be also posting that available for view and review afterward to our website. So we'll send out a link to that along with a brief survey that we would really appreciate you complete. It's just a few minutes, not very long, but really important information that is going to help us to improve and better serve future audiences. So at this time, I would like to welcome Abby Lee Hallett to read for us the land acknowledgement.
Right. Thank you very much, John. Before we begin today, I would like to take a moment to acknowledge that the land on which we gather today is comprised of the traditional territories of the Three Fires Confederacy, made up of the Ojibwe, Ottawa, and the Potawatomi nations, and the ancestral and unceded territory and waters of Caldwell First Nation, whose people are the original people of Pelee Island and Point Pelee. The Ojibwe, Ottawa, and Potawatomi nations agreed to share this territory with the British Crown by way of the 1790 treaty referred to as the McKee Purchase or the Treaty of Detroit. This territory is the home of the Anishinaabe, who are represented by the Walpole Island First Nation, and the Lenape, who are represented by the Delaware Nation. I, as well as the Working Toward Wellness Committee, recognize the historical and present impacts of colonial violence on the Indigenous peoples of Canada. I identify as a settler on this land, and I acknowledge my commitment to the calls to action from the Truth and Reconciliation Commission of Canada. We are privileged to gather here today on these lands and affirm a commitment to continue to learn from Indigenous knowledges and practices.
Thank you very much, Abby Lee. So without further ado, I would like to introduce Sylvie Guenther, Executive Director of Hiatus House in Windsor and the co-lead of the Violence Against Women Coordinating Committee for Windsor-Essex, to say some words about today's topic initially, and then to introduce our keynote presenter, Jason Petro.
Thank you. Welcome, everybody. Hopefully you enjoyed today's webinar. I'm certainly looking forward to it. You're going to get to hear about workplace violence and intimate partner violence and how it relates to each of us in our own workplaces and what we can do together to prevent it. I want to thank the Working Towards Wellness Committee for organizing this session. It's a topic that we don't often get the opportunity to talk about in the context of our workplaces, and yet it's so important to do so. There's a slide up on your screen. The Ontario Association of Interval and Transition Homes, OAITH, started tracking media reports of femicides in 1990, and this is for Ontario. And since then, the list has evolved, and now the femicides in the province are being reported monthly. You'll have a link. You should have a link to that in your chat as well as it's showing up here on the slide. Femicide is broadly defined as gender-related killing of women and girls by men. And to give you an indication of the trends for femicide in Ontario, and you will see here the number for the end of June, I'll say that in 2021-22 reporting year, there were 52 killings reported. And then the following year, the 2022-23 year, there were 62 killings reported. And in the first 8 months, so this takes us to June, but from June to July, the total number of deaths reported in Ontario were 42. So from 35 to 42 across a month. And, you know, this includes the killing of both women and their children, and only represents those that are publicly reported in the media. They're not indicated by, you know, the report is not generated through coroners or police reports. And it's important to know that, because that these numbers of femicide are underreported in the media, and often there's a publication ban around them. So just to qualify that these numbers are only representative of those media reported femicides, and will certainly be missing some people. And if anyone's looked at these reports, they are quite impactful, and there, as I said, you have the link. It's important that we come together like this to talk about the issue of intimate partner violence and gender-based violence, to get a better understanding so that we can act in order to prevent such violence long before it leads to femicide. And this is where you come in. And I was pleased to hear about the number of people who registered for today's event. It shows that, you know, we're all going to benefit from what we hear here today. And I have the pleasure of introducing Jason Petro, your presenter for today's event. Jason has been working at Hotel-Dieu Grace Healthcare since 2013 and is currently in the role of the Safe Workplace Advocate. Hotel-Dieu Grace Healthcare has been a leader in our community for addressing the issue of intimate partner violence within the workplace. A little more about Jason. He's been working in healthcare since 1992, where he started as a cardiac technologist at Windsor Regional Hospital, and was part then of the initial development and implementation of the Cardiac Wellness Center that was the first medically managed multidisciplinary cardiac rehabilitation program in the province. He joined Hotel-Dieu Grace in 2013 as part of a realignment at that time with the hospital system. And there he's had the opportunity to oversee a number of different kinds of projects and programs that have led him to his current role today. So thank you, Jason, for providing today's presentation, and I turn it over to you.
Thanks, Sylvie. Let's get going here. And that's a very kind introduction. And I must thank you for all your support to the community at Hiatus House, because that's a very important service that you provide. So again, thanks to the Working Towards Wellness Committee for inviting me here today to talk to you about kind of our robust program here at Hotel-Dieu Grace Healthcare. You know, even though this presentation will be focused on our hospital environment, there are aspects that can be modified to work in the private sector, tourism, not-for-profit organizations, service industry, or other working environments. This presentation is an opportunity for us to share our unique program with you. However, it's not meant to provide direct consultation to handling these matters in your own workplace. So while I report directly to the Chief Human Resource Officer and I have monthly meetings with our CEO, I do work closely with our Director of Human Resources and Occupational Health and Safety, Manager of Human Resources, Manager of Occupational Health and Safety, Manager of Security, and Patient Advocate. Now, as a result of when I got this job, my office was moved to this location, which is part of occupational health and safety. But because there sometimes can be some negative associations with HR from the employee's lens, I do have an access door to this kind of hallway over here. It's kind of not a very busy hallway, so our staff can come in to my office without having to go through HR. And security is just down the hallway as well. So if anything comes up, everyone can come together very quickly to deal with any situation. Now, the position itself was created following the Lori DuPont intimate partner violence case in 2005, where Lori, a nurse, was brutally stabbed to death by her ex-boyfriend, a physician who she had worked with while working in the ER of Hotel-Dieu Grace Hospital at the time on Olette Avenue. This unfortunate event made national news and ultimately was a catalyst for positive change. The inquest that followed this event resulted in some major changes to policies at the hospital and further influenced significant changes with the Occupational Health and Safety Act, more specifically with Bill 168. So the main change with Bill 168, meaning all employers with greater than 5 employees must have policies in place on workplace violence and harassment. And more importantly, if an employer becomes aware of a domestic violence or intimate partner violence situation with one of its workers, they must act to protect that worker and the workers around them. So I'm involved with a number of different things in my job, workplace violence issues, code of conduct issues, culture audits, which I'll explain later, safety plans, behavior contracts, and again, intimate partner violence. Involved with many committees in our organization. And sometimes to simplify this, when I introduce myself to a patient or family member, I typically say, hi, I'm Jason Petro. I'm the Safe Workplace Advocate. I'm here to keep you safe, all the staff safe, and anyone coming into the hospital safe. So on to the policies. So essentially my role revolves around these 3 policies at Hotel-Dieu Grace Healthcare. And while I'll be sharing aspects of these policies at this time, I'm not able to share every detail of those policies as part of this presentation. Now, we advertise very front and center that we have a zero tolerance policy for violence. This sign is up against our CPH building. We have a similar sign over on our Imara building. We put this up on our electric sign outside on Prince Road. This is in our patient welcome package. This is noted in our hospital orientation for new hires. And even when physicians gain privileges at HCGH, they meet with me and I talk about this. So it is very fulsome. We want to make sure everyone's aware of this, that there's a zero tolerance policy. Now, the Occupational Health and Safety Act defines workplace violence as an exercise of physical force, an attempt to exercise physical force, and a threat to exercise physical force. Now, thankfully, we haven't dealt with many situations of actual physical force, but it does happen. And threats, I must admit, it can be a perceived threat. And in my past life as a manager of ambulatory services, I even had a disgruntled worker say to me once, I just want to let you know that I know people. Well, that's kind of a threat. And I had to take that very seriously, and I brought that to HR. Now, there's a number of different physical workplace violence scenarios, and these are things that we hope that our staff document and tell their managers or supervisors about, and we certainly want to take those very seriously. But workplace violence could come in all different shapes and sizes. It could be an external perpetrator, a patient, client, visitor, family, could be staff, and again, domestic violence or intimate partner violence. And as I talk about all these aspects of the policies, it's important that my involvement and approach may vary based on who's involved. These policies work if it is our patients or if it's our staff that are involved in this situation. It's interesting to note that more recently, we've seen an uptake in family-related dynamics that has created more issues and kept me busy. Now, we do have PALs, and these are delivered to every employee and every physician in the organization. And these PALs are used at Windsor Regional as well. And there are devices that can be used by our staff in emergency situations where they can press both of the buttons, alarm sounds, security is alerted, and there's an overhead page. Overhead, security quickly responds to that area. Now, this is incredibly important, and I pound this into our staff that they have these for a reason, and it's for their safety. And it does provide a great opportunity for us to act quickly in certain situations. Now, with any different workplace violence scenario, corrective actions could play a role if it's a patient or visitor, and sometimes we may have to remove that person from the premises. I'll talk more about safety plans. We may put in a no trespass order and report that incident to the police. Now, unfortunately, if there's situations where this comes up with staff, counseling or training may happen with that particular staff, and depending on the scenario, disciplinary action, suspension, or termination may result, and we may have to report that to their college. Now, with respect to supporting our staff, we do have nonviolent crisis intervention training for every new hire coming in, and refresher courses every 2 years for high-risk staff. And the main focus on this is non-restrictive interventions and verbal de-escalation. Now, we also have pre-home visit assessments that we do with our outreach staff. So when our staff go out in the community, they fill out a form to see what is the risk going out into that home in itself. And that is very important to determine risk going into the home. We also have a security, in-house security, which is very important. That changeover happened a few years ago, and that has helped that we have a consistent staff that we all know, and they're given additional training on restrictive interventions that could play a role. And what we see this more so is up on our mental health units, inpatient units here. Now, documentation is critical in these matters, and we do have what's called the safety reporting system, which is a separate electronic documentation system where our staff can document instances in the safety reporting system, and I'm able to view every single one of those as they're entered in. And again, there's only so much I can do if I see those. If I don't see those instances in the documentation, and if people don't come forward, it poses a problem. Depending on the scenario, we may do investigations, and if it's a fairly serious matter, we can do threshold case reviews where we bring in a number of people from different parts of the organization to talk about things and maybe how we can mitigate future instances like that. Now, the second policy that we have is Code of Conduct, Prevention of Workplace Harassment and Workplace Sexual Harassment. And sometimes when certain behaviors occur that don't meet the definition of workplace violence, it usually falls under this category of Code of Conduct. And you know, interestingly, this is actually our covenant that we have here at Hotel-Dieu Grace Healthcare, and it was first developed as part of the whole post-inquest of the Laurie DuPont situation. And this is actually a little bit of updated version of this. And we have our staff sign off on this annually. And more importantly, there is a little piece here that I added in here about confidentiality, not just with respect to our patients and clients, but also with our fellow co-workers. And I'll talk about that later on with respect to intimate partner violence. Now, for the most part, there seems to be some blurred lines with respect to some of our staff and maybe even our patients that come in that scream that someone's harassing them. And it's important to understand the differences between harassment and, say, bullying. So harassment, generally, I like to say that it's persistent and repetitive behavior, creating an abusive environment. And it's usually directed at a protective class or prohibitive grounds. So what I mean by that is if someone's using something or saying something with respect to your race, sex, sexual orientation, disability, or whatever have you, that usually becomes a little bit more serious matter, and it can be defined as actual harassment. Now, with respect to sexual harassment, this is actually the what's in our particular policy, but what I'd like to do when I explain this to our new hires in orientation is that someone can't touch your private parts, talk about your private parts, make unwelcome sexual advances, or leverage anything sexually inappropriate for advancement or threatening job security. Surprisingly, this is a fairly common issue that I'm asked to deal with up on our inpatient units when patients don't understand their boundaries. While there are situations where this comes up with patients with cognitive deficits, there are still those patients that are fully aware of what they are saying and that have to be spoken to. Now, everyone has a responsibility to a safe working environment, and I do tell the staff that they are the first line of safety, and it's important that our staff confront patients' behaviors head on, but it's also important for them to report it when it happens, regardless if it's a patient that has cognitive deficits or not. Once it's reported, we must address it. So I do want to mention a little bit about bullying. Unfortunately, I do see a lot of scenarios where bullying is occurring in the workplace. Typically, the common thread here is intent to intimidate, offend, or humiliate a particular person. As well, there is a sense of someone is trying to assert their power over someone else. And, here's a number of different examples. And quite commonly, I hear, swearing, yelling, setting someone up for failure. I see this with the way that some of our patients and families treat our staff. Well, unfortunately, sometimes it's the way our staff are treating each other. Now, sometimes I say that some of my job is dealing with high school drama, and most of this revolves around gossip in the workplace and can be a contributing factor to departmental dynamics and performance. And, when these things come up within our staff, sometimes staff come to me and we can have independent reflection and talk about things. Sometimes they realize that maybe they're part of the problem, and I can even offer up Family Services Employment Assistance Program, maybe offer mediation. Depending on the scenario and the degree of it, I might have to get human resources or the union involved in this. And even though in those such scenarios, I'm more than welcoming to have union representation during these sessions. Sometimes it involves external investigations. And I've had a couple of scenarios where, in particular, 2 staff have come to me saying, this person's harassing me. And essentially I say, this is not harassment. And they say, I want an external investigation. And I can't deny that. In both cases, external investigations were done. There were no foundings harassment seen in the situation. And part of the recommendations were mediation with me. So it came full circle. I do culture audits as well, and culture audits is kind of a questionnaire, a 30-question questionnaire on a 5-point Likert scale, and it allows me to look at different things and perceptions of our staff in a particular department, and the staff can put in their own comments, and I ask that they don't put their name in. Usually I generate a report, and that report goes to our frontline staff. After that, I ask that staff come forward to create a focus group where we can talk about the report, and I act as a mediator between the focus group and the managers of that unit. And ideally, after the focus group work is done, we would repeat the culture audit in 6 months to see if there were any changes in the perceptions of the staff. Now, again, I do have a lot of times where I have to deal with patients and visitors and family members. And again, sometimes it's having independent reflection with those people. And when I'm talking with our patients and families, I usually take a person-centered, I always take a person-centered approach. And I think it's key here because after saying who I am and listening to their story, it does allow for an easier way to confront the difficult conversation that I may have to have with that patient or family member. Now, it may result in some behavior plans, safety plans, and chart flagging. We do have a behavior plan order set in our electronic medical record called Cerner, and that just identifies a particular behavior for the nurse that's assigned to that particular patient on each shift, so that there's a heads up. And we might bring in the responsive behavior navigator. We've put signage outside the door, and this is done quite frankly, with our restorative care portfolio. It's not done in our mental health stream because they have quite a robust behavior plan that they do on all the patients there. Sometimes I have to implement what we call a behavior contract, where I literally put in here for a person, a family member, or a patient, do not swear. Be respectful to all the staff. And I have them sign off on this. And obviously, this is people that don't have any cognitive deficits. And surprisingly, this works very well. One of the things that we also implemented here was this behavior signage. This purple sign goes up on the door, and everyone's aware of this at new hire orientation. So everyone's aware of this sign. And if you see the sign outside the door, especially for staff who are non-clinical and may be going into a room like dietary helpers or ES workers, they can go back to a nurse and ask, what should I know before going into that room? They can also look at the safety plans that are posted on the safety plan whiteboards on the units. Now, I've talked a lot about safety plans. This is a lot of my bread and butter here at the hospital. We have safety plans that are usually developed after there's a particular incident with a particular patient or family member. We can have awareness plans as well, and this is maybe we have a patient coming over from Windsor Regional where they've given us a heads up of a particular behavior, but they haven't actually done anything at our hospital. So we might have an awareness plan to give everyone a heads up, and that can easily be switched to a safety plan if something were to arise. This is kind of what our safety plan looks like. We identify the person of interest, and we may include pictures from social media or surveillance cameras. There's a brief description of what events led to the actual safety plan and clear direction on what we're going to do to mitigate any issues moving forward. I do want to mention that every single one of my safety plans, they get delivered to all of our leadership, the managers of the unit, even the unions, union member heads who have staff on that particular unit or wherever that's taking place. And it's shared electronically and it's password protected. Now, Cerner also does have a chart flagging mechanism up here in the banner bar and the alerts, where what can be done is we identify patients as AOB, and the AOB typically has been known to be acting out behavior. However, I am trying to change that narrative and use the term awareness of behavior, because sometimes it's patients that have cognitive deficits who, unfortunately have behaviors. And we want to make sure that when families understand that they have their loved one flagged as an AOB, that it's in the best interest for everyone to have this knowledge so that they can deal with any situation, even themselves in those situations, moving forward. Now, the last policy is our domestic violence, intimate partner violence policy. And again, with the push to have intimate partner violence recognized as an epidemic in Ontario, there certainly has been more media attention given to this as cases have increased over the past several years. And we've had, the heightened awareness with the incident in Harrow recently. And as Sylvie mentioned earlier, the amount of reported is certainly underreported. across the board. Now, understanding IPV, while this is not an exhaustive list of things that could increase the risk of IPV in our community, factors like social isolation during the pandemic and our recent economic stress through higher interest rates and cost of living could certainly be driving these numbers upwards. I do want to mention that while IPV cases against women are more predominant, I have had cases where males have been the target as well as same-sex partners. Now, we think of intimate partner violence typically as sexual abuse or physical abuse, but it can come in many different forms. And it's important to note that and not take any one of these lightly. Now, with respect to being an employer in this situation, could be a number of things that could be red flags when it comes to identifying someone dealing with IPV. With respect to job performance, we sometimes may forget that there is a whole other personal side to our employees, and especially if you have an employee that has typically been a strong performer, and then you see a progression to poor performance, maybe there's an opportunity to ask the question of that person, maybe in a coaching session, like maybe saying, I noticed that you have been making some more errors of late and not talking to your coworkers as much. Has anything changed in your work environment or at home that could be impacting your job performance? Asking an open-ended question like that, I think, is important. And while it doesn't guarantee a response from that person to open up about if they have an IPV situation going on at home, it certainly allows you to open that door and hopefully they come forward. Now, responsibilities for us as employers, we obviously have to provide a safe working environment for the victim and coworkers. It includes if they work off-site. So we have a number of remote workers or outreach workers who go into patient homes, and you may have to change that, and maybe they have to work remotely or virtually from from our main site. There are a handful of staff that we do have here that work from home, and while it wouldn't be a thing that we'd have to have security at their home, maybe they would have to come to work in this environment to be more safe. So changing their location, scheduling are critical factors. Guidance to the victim is important, but not counseling. You don't want to really counsel them on what they have to do because there could be liability issues as an employer. But you still want to talk to them because they could be coming to you very scared and they might not know what to do. So they may have to understand whether or not maybe a restraining order or a no contact order or peace bond makes more sense to them. And that supports are available to them. And that may come in different forms, whether that's supports in the community or even as an employer, you have the discretion to provide paid leaves of absences to help support them get through this time. Confidentiality is critical here, maybe even changing the directory. So we might take them off the directory at the hospital so that people can't get their actual extension. And we have to also understand that they have to understand that there's a clear understanding that we can't protect everything while they're not at work. And we're protecting them in their work environment. And ultimately, in these situations, we do a safety plan. And this is the safety plan looks very similar to what you would see for our internal safety plans for our patients. And this is kind of just a worksheet that I use when I meet with a person coming forward. And I might ask about if there's any history of abuse, violence, any history of charges being laid against their partner. Is there any employment issues, financial issues? Access to weapons is really a critical question because that could heighten the risk of this particular safety plan and how I go about things. You know, does their partner know exactly where they work on campus and where they park? Are they currently in a different relationship? Could that have impacts on things? When were the timelines? And sometimes, like I'm being told this information at the 11th hour, and this has been going on for months, and understanding their supports at home. Now, I don't put all that information in the actual safety plan, but I do share the safety plan with each person so they can see and understand who is going to have this information, who I'm sharing this information with. Now, as again, some of the things we may end up doing is, even if this is on the units, we may have to put memos out to remind staff, not if they're asking for anyone on the unit, that they should, refer to their manager and maybe say, you know what, we can't answer those questions on whether or not that person's working this shift, but if you can leave me your name and number, I'll get my manager to call you back. We could arrange secure parking for that individual, again, reminding them of their PAL usage. We'll get photos, again, reminding of community resources that are available to them. Now, in the actual safety plan, the things that I might do is get information about the car that they drive, the car that their partner drives. And for instance, here, we had 2 instances where people came forward about abuses, and their partners, their boyfriends, lived in the States. In both cases, both of their partners own multiple guns. So I did make a call to border security and informed them of this individual. And I also pushed the envelope and said, you know, it's important that you report this to the police, and because that can triangulate the information between all parties and keep you safe here on the Canadian side. So in case scenario, the person tries to cross the border, the Windsor police will be notified of this, and they could actually go and apprehend that person if there's concern of actual abuse. Again, we have different areas on the hospital grounds where we can get the person to park. That's kind of out of sight from the main roads around the campus. Again, pushing the envelope that they can go talk with FSEAP and understand that they can get security escorts. And so I know that not every employer has security, but you might have a friend or a colleague meet you at your car when you arrive and escort you in. One of the non-negotiables that we have on here is lower here with respect to if a person doesn't show up for their scheduled shift. Now, automatically we would call that individual, maybe they slept in, but if they don't respond to their cell phone, we will have an emergency contact contacted, and it's their responsibility to check in on that individual. If they can't confirm their safety, we will do a wellness check and call the local police and conduct that wellness check for that individual. Now, because a much smaller group of people are involved in knowing about external safety plans, because we want to keep it confidential, we have this long-winded algorithm to support all staff and how that information is handed over. And essentially, it's our security staff that are here that have access to these and can deal with the plan of calling people. So again, in any situation like this, I even hand this out right away to our staff at hospital-wide orientation, but we do have this intimate partner violence resource sheet that all of our staff are given. This is on our website, on our intranet site for our staff. And I do also keep track of all of our statistics in our report on a quarterly basis. And I think this is really important to share with our frontline staff. And I've started sharing this on our safety plan boards on the units, because I think it's important for our staff to understand where the issues are coming from. There's nothing here, that's all confidential information, but we can see where the contact is. Is it intimate partner violence? Is it a worker-to-worker situation? Is it patient-to-worker? Is it family-related? Because sometimes it's not even to do with us, it's just patient and family dynamics that are causing problems on our unit. And you can see as each quarter goes by, things can change quite dramatically. And in a lot of cases, we have scenarios here where we might have a lot of situations or events, but in a short period of time, they get closed because we've resolved those cases or the patient is discharged from our organization. Now, I can imagine, not everyone can have a safe workplace advocate, and your organization may have different leadership structures than what we have here at Hotel-Dieu Grace Healthcare. And we don't have all the resources to have these things, but building a culture of trust and respect within your organization is a critical foundation when addressing these policies as a whole. Continuing to educate all staff on the importance of workplace violence, workplace harassment, and intimate partner violence is a team effort and will pay dividends for any organization moving forward. Now, there are a number, again, I just wanted to remind everyone that there's great resources within our community that are available to support our employees. Remember, providing these resources is an important step when supporting everyone who works for us. For employers, there's a number of good resources that you can use to further increase your comfort level when dealing with these situations. In fact, the Canadian Centre for Occupational Health and Safety, there's some really good information there as well. And here are some other resources that are available and you might want to review at a later date. Again, I want to thank you all for listening today, and we'll take a little bit of time to stop recording this webinar, and I'll try my best to answer a few questions, time permitting.